Thank you very much for the introduction and the opportunity. I think everything has been said already. So for me it was difficult what to talk about, and my only disclosure is that I had no previous insight what the talks were we just heard about. So I decided let's take a short overview. This has been already mentioned. Responses to the phase, and also what Ian Loftus told us about, and where did it go wrong. Only RCTs were leading. And in an attempt to go for an independent members, it's a bias and it's wrong to presume that people who have not a consultancy should be more neutral than people, colleagues who have a consultancy for one kind of firm at all. So it's full of assumptions, full of biases, and that is not the way to discuss it with each other. Prospective close observational studies were not appreciated in the correct way. I think in the past, those close observational studies were superior to any other method. However, we neglected the pure way of observation and the honest way to report prospectively. And for that, the randomized controlled trials were a blessing. And the blessing is that those randomized controlled trials are still superior in having the right decision, what is the best method to be used. Major improvements have been mentioned already, but they were ignored when the analysis were performed using those randomized controlled trials. But the most important is the currently available outdated randomized controlled trials are marginally powered, and last year we had many of those presentations showing how marginally this is. At short term, and also heavily underpowered at long-term follow-up. Actually, it looks a little bit like a spoiled child, as I mentioned. I want to have a unicorn. Okay, we can offer you a black pony or a white pony. Maybe a white pony? No, I want to have a unicorn. I know that the randomized controlled trial is underpowered. I should not use it, but still I want to have the unicorn. Okay. What about something about powered and unpowered? Survival after abdominal aortic aneurysm is associated with socioeconomic status. That whole cost-effective story is a political situation. If you pay your nurses less in the UK than, for example, in another country, then immediately the price is flipped over. This was presented in a journal, and we are going now to present more and more, but politically, this is a very difficult subject. The conclusions of this study, published in the JVS, was that the long term, and I emphasize long term after 10 years, is associated with the social economic status. Further studies are required to assess the risk factors. And they are responsible for the decreased long-term survival in low socioeconomic status patients. I will not use the example of the River Thames or the Clyde. I stay with the River Rhine in Holland. People at the south border in Rotterdam live about 15 years shorter than on the other side of the border. No politician wants to know this. And how is the nice guideline committee able to make a socio-economic valuable analysis, not taking into account these high differences in outcome depending on your social economic status. So when long-term results of RCTs are being used, thousands of patients are needed to come to valid conclusions. And because the biggest confounding factor for long-term risk at this moment, at overall morbidity and mortality, when you do not show up for a control, etc., is by far the zip code. And reappraisal for prospective close observational studies is justified, and I would recommend those when it's not possible to get those high numbers without an enormous financial support and a very long way to get that proof for the glorified randomized controlled trial. And I thank you for your attention.